And so our first speaker is Dr. Martha Louzada. And Dr. Martha Louzada is a malignant and benign hematologist with us at London Health Science Centre. She serves as the head of the Hematology Research Unit at the Verspeden Family Cancer Center, and is also an associate professor within the Department of Medicine, Epidemiology and Biostatistics and Oncology at Western University. With a specialization in hematology, her research and clinical work emphasizes multiple myeloma and venous thromboembolism, particularly focusing on cancer-associated thrombosis. Her dedication extends beyond clinical treatments to include an interest in the quality of life and psychological well-being of patients with hematological malignancies, especially those undergoing bone marrow transplant. And so her talk title is as listed, Monoclonal Gammopathy, Understanding the Role for Screening, Risk, and Monitoring for Progression. These are her disclosures. These are the learning objectives. Discuss role for screening for MGUS, define monoclonal gammopathy and its clinical significance, and summarize the monitoring and management strategies for patients with monoclonal gammopathy. I'm going to start off with the case, but I'll invite Martha to come up here. So we've got a 62-year-old male, retired teacher. We're going to call him Richard. He was identified to have IgG lambda monoclonal protein while donating blood. And so CBS does check the blood that's being donated, and sometimes it will identify monoclonal gammopathies, and a letter will be sent to the patient's home. Richard does not have significant medical history. He's a non-smoker, moderate alcohol use, and no significant findings on initial physical exam. So the first question is, what initial investigations should be implemented when identifying monoclonal proteinemia? And the second question is, what are the risk estimates for progression from MGUS to a plasma cell or lymphoproliferative disorder? I'll leave that there for a moment here. And so these are your options: A, CBC, B, renal function and calcium, C, SPEP, D, serum free light chain, and E, PET-CT. And so you can pick all that apply. So you can look at your app and pick your answers. Once everyone's answered, Olivia, just give me a thumbs up. We've moved on to a different question, it looks like, hey? That's the other question is what you're saying. Okay, so maybe I'll just answer this first. I think here we would say A, B, C, and D would be the right answer. PET-CT has its utility, but not at this initial juncture. So now moving to question number 2. Avi, can you go back, please? I'm trying to move to the next question. Okay, maybe we'll avoid the switching back and forth. I'll just answer it on my own. Yeah. Thank you. And so here, what are the risk estimates for progression from MGUS to a plasma cell or lymphoproliferative disorder? Pick one right answer. 5% in 20 years for low-risk MGUS, 35% in 5 years for high-risk MGUS, and 80% in 2 years for high-risk MGUS. And so the answer here is A, 5% in 20 years for low-risk MGUS. And so patients who have no risk factors for their MGUS, the risk of transformation is truly quite low, and this number is often very reassuring to patients. All right, so I'll hand it over to Dr. Louzada. Thank you.
Good morning, everyone. This is a beautiful, beautiful audience. Thank you for taking the time to be with the London hematologist this morning. So we're going to be talking about monoclonal gammopathies, mostly MGUS, and see when they're relevant, right, for us to investigate and follow. So We know that MGUS is a pre-malignant monoclonal. Oh, is it going? Yeah. Yes, no, we're good. We know that MGUS is an asymptomatic clonal plasma cell disorder that is characterized by the presence of monoclonal gammopathy less than 30 grams per liter, plasma cells in the bone marrow less than 10%, and there's no evidence of end organ damage that would be suggestive to be associated with multiple myeloma or other plasma cell dyscrasias or any lymphoid malignancies. Our role for investigating MGUS is because we want to know if there is any problem for the patient in terms of risk into developing a sinistrous malignancy. And we also want to be able to stratify the patients. And for that, we need to have the appropriate investigational screening plan. MGUS is quite prevalent in our population. It is present in about 3% of patients or persons at age 50 or above, and it goes exponentially higher with the passing of time, up to 7.5% among those with 85 years of age or older. It is slightly higher in men than women, and it is mostly prevalent in African Americans compared to North American Caucasians. And this risk is lower in Asians and Mexicans compared to the Caucasian North American population. So when we look at our case, we had a 62-year-old male that had an incidental finding of IgG lambda monoclonal gammopathy in his blood when he was attempting to become a blood donor. And this is actually one of the most common ways to diagnose a monoclonal gammopathy. The important thing about defining the type of monoclonal gammopathy is, number one, its subtype. It's very easy when we have an SPEP that states there's evidence of monoclonal protein. But if we don't have an immunofixation that actually gives us the typification of the monoclonal plasma cell, this poses a somewhat limitation in our understanding of the prognosis of this monoclonal gammopathy. So it's very important that we know if our monoclonal gammopathy is IgM-based or non-IgM-based. Most of MGUSs and monoclonal gammopathies in general will be non-IgM, meaning IgG, IgM, IgG, IgD, or IgA. 85% of cases, and a minority of them is going to be related to IgM. The important thing about this is because the non-IgM MGUSs will tend to promote, if they progress, they will progress most likely into overt multiple myeloma. And the IgM MGUS will most likely progress, if it progresses, into Waldenstrom's macroglobulinemia. Interestingly enough, 2% of IgM MGUSs can also develop multiple myeloma, can turn into multiple myeloma. And when we talk about different monoclonal proteins, light chain MGUS, 20% of multiple myelomas will be light chain only. So we can see a little bit of a mix and match there. Continuing with this, non-IgM monoclonal gammopathies can also be present or be associated to lymphoproliferative disorders, but not Waldenstrom's. Waldenstrom's is a lymphoplasmacytic lymphoma characterized by being IgM associated, but you can have other lymphoplasmacytic lymphomas, other lymphomas, CLL, that may have other monoclonal proteins such as IgG or IgA. And talking again about light chains are very much associated with what we know as AL amyloidosis, AL standing for light amyloid chain, but AL amyloidosis can also have a second entity called heavy chain amyloidosis. We call all of them as AL because they all come from a monoclonal plasma cell, but you can also have patients with AL amyloidosis having heavy chain IgG, IgA, or IgD monoclonal gammopathy. This is a bit of a spider's web, right? So just with this slide, I could say, okay, let's stop it because this is too confusing. So the idea is to try to detangle this for you so that you can understand why the importance, okay, to know your subtype of monoclonal gammopathy. But before I do that, I have to state that not all monoclonal gammopathies of uncertain or undetermined significance. We do have monoclonal gammopathies of clinical significance. There are several of them. I personally find them somewhat difficult to ascertain and many times to follow. It usually involves a multidisciplinary team. And the characteristic of the monoclonal gammopathies of clinical significance is that even though they fulfill criteria for MGUS because they do not present with plasma cells in the bone marrow that are monoclonal in the ratio of 10% or more, you don't see a monoclonal protein above 30, but they do cause organ damage. And this is why they deserve special attention. And as I said, usually a multidisciplinary team, because you can have a monoclonal gammopathy that's impacting on your kidneys, which is the MGRS that you can see there in blue, or you can have neurological complications, dermatological complications, you can have ocular complications and many others. So I'm giving you just a few examples there, but there are many monoclonal gammopathies of clinical significance that are out there and deserve our attention because they can get somewhat easily missed if they're just perceived as being a simple MGUS. So the best initial investigation when you understand that your patient has a monoclonal gammopathy is what Dr. Puwo was mentioning. Start out with simple tests, right? So CBC differential, ideally a peripheral smear. You also want to know your baseline kidney function for your patient. Albumin, calcium, LDH are preliminary tests that you can have. SPEP is important, as well as serum-free light chain assay. Serum-free light chain assay not always available because it's not covered under OHIP, so patients have to privately pay if they don't have a private drug plan. But the test is not excessively expensive; it's around $50, so somewhat doable, especially for an initial screening test. But if you don't have access to the serum-free light, you should at least do a 24-hour urine assessment. Although I have to state that 24-hour urine protein electrophoresis in MGUS is usually negative, so not the best test at this point. You should try to get the free light chain. But when is a 24-hour urine important? It is important if your patient has low albumin, because low albumin may reflect a very early stage of amyloidosis, and then you want to do a 24-hour protein assessment to assess albuminuria, nephrotic range proteinuria, and the presence of a monoclonal gammopathy in the urine. And always remember 24-hour urine, not spot urine for your initial investigation. The other thing is the IFE, right? We want an immunofixation because the ASPEP, we get a lot of referrals with ASPEPs that show there is a monoclonal gammopathy, but then we don't know what it is. So in your initial investigation, request an immunofixation of the serum, or if you're doing urine, of the urine, so that you know, and if you refer the patient to us, we know which protein that is. That's already half of the work done to help the patient. So then in our case, what do we do, right? We know that this gentleman has an IgG lambda. What is the problem, and what do we discuss with this patient about his risk of developing a malignancy in the future? So obviously we start out with what we just discussed in terms of preliminary screening laboratory tests. And just to go over very briefly with you, we can state that IgM MGUS usually incurs a risk of about 1% per year into development to a lymphoproliferative disorder or plasma cell dyscrasia. The non-IgM MGUSs will lead to 0.5 and the light chains 0.3% per year. But we can do better than that. We can risk stratify our patients better. So here I have in this table results from a Mayo Clinic study that looked into over 1,000 patients, and they found out that they could consider low-risk patients, patients that had a monoclonal protein that's less than 15 grams, a monoclonal protein that's IgG subtype specifically, and a monoclonal protein that has normal FLC ratio. So if you have these three, then you have a very low risk of development into overt myeloma or other malignancy of about 5% that you can see there. But if you account for competing causes of death, this can be as low as 2%. If you have one of these levels here abnormal, then this risk goes a little higher to about 21%. If you have two of those abnormal, then it goes to about 37%. And if all of them are abnormal, such as you have an IgA with 20 grams of protein and abnormal FLC, then that will give you a higher risk for progression into overt myeloma or another malignancy of about 58%, cumulative risk in 20 years. So overall, the risk is low. But obviously, it gets a little bit worse as your risk stratification predictors are more and more abnormal. So in this slide here, I want to show you, I hope it's big enough for you to see. We're talking about what to do, right, in terms of decision making. So what do we do with our patient with monoclonal gammopathy of undetermined significance? If this patient is a low risk patient, as I just mentioned, with IgG, less than 15 grams of protein and normal FLC, this patient is an uncomplicated patient, and the yield of a bone marrow and a skeletal imaging at this point is very low. So it's usually about 2.5% the chance that you're going to get a positive bone marrow, and less than 5% chance that you're going to get a positive skeletal survey for abnormal bone lesions. So this is not necessary for this low-risk patient. I don't know if you can see there, but also low concentration of IgM is also considered to be low risk. And we have to consider that most of these patients are Waldenström's, are going to develop Waldenström's in the future if they do. And those patients usually don't have bony lesions, so that spares them from having to have imaging. And if the patient is completely asymptomatic, it's also unlikely that a bone marrow at this point of diagnosis is going to be of any utility. This way, you spare the patient from having the discomfort of having a bone marrow, and you also spare healthcare resources. It is important, though, for you to understand that about 50% of MGUSs that are diagnosed are low risk. So the vast majority of your patients will actually not require long-term follow-up. And then I pose the question, is it worth it to send this patient to hematology? Right? So this is just a food for thought that there for you guys. However, all of the other patients should receive or should get skeletal imaging as a skeletal survey, X-rays, or a skeletal CT. And ideally a bone marrow aspirate biopsy as well. Okay. Now, the International Myeloma Working Group recommends following these patients after the initial diagnosis 6 months later with the usual screening with CBC, creatinine, SPEP, FLC, if they are considered to be intermediate risk or high risk. However, if they are low risk, oopsie, I'm going to go back here. If they're low risk, they actually don't warrant any specific follow-up. And obviously, on the right-hand side here of this figure, if they look like they have an active malignancy, then that needs to be appropriately assessed and conducted. But continuing here, for the patients that are intermediate or high-risk MGUS, personally, I like to follow them every 6 months for the initial year. And this is based on the fact that Mayo Clinic has published a couple of studies demonstrating that the risk of transformation of MGUS is highest within the first year, but the risk is still 2%, and then it goes down to 1%. So I like to follow my patients every 6 months during the first year, and then after that annually with the screening that we know with CBC, creatinine, SPEP, FLC, albumin, and calcium. And the other thing that the International Myeloma Group question, it's a question that they pose that's written down there for you, is we can reconsider a few patients, such as patients that are older than 80 years of age, or if the patient has expected life expectancy less than 5 years, maybe you don't want to be following this patient. So I think this is an individualized discussion to have with the patient and family members. But otherwise, everybody should continue follow-up. So to finalize my talk, I'm just showing to you here the iStop-MM website. This is a calculator for risk stratification for patients with MGUS. They use the same concept of the Mayo Clinic with the type of monoclonal gammopathy, the concentration of the monoclonal gammopathy, the free light chain ratio, but they also use the serum IgAN, so the total IgG, IgA, and IgM, as being predictors of risk of, not risk of progression, but need to perform a bone marrow aspirate biopsy. So this is an adjunct in the decision-making for which conduct we're going to take with our patients. The iStop-MM trial is a prospective study performed in the population of Iceland. It has been going on now for many, many years. More than 14 persons participate in this trial, with about 1,000, a little bit more than 1,000 having been diagnosed with MGUS. And these patients are being followed over time so that we understand better how relevant the monoclonal gammopathies are. So this is just a little sideline there for you guys. And we still have 3 minutes left. So I thank you very much for this opportunity, and I'm happy to answer any questions.
I've got a mic here if anyone's got any questions.
Hi, thank you for the talk there. I'm a family doctor, and two of the most common situations we would look at ordering SPEP along with the other tests. One would be peripheral neuropathy, polyneuropathy, and the other one would be some type of anemia that we don't have a clear indication with the cause. So in those situations, just to clarify, you would order SPEP, immunofixation, and serum free light chains?
Absolutely.
Okay.
Yeah. And it's very important to have the full screening done because you can have a patient with two different disorders, right? The patient can have an MGUS and have anemia because of another reason, right? So you have to actually investigate two different entities. The same thing with the peripheral neuropathy. What we don't want to do is to miss an early multiple myeloma, right? But we also don't want to diagnose the patient wrongly. And the same thing with the peripheral neuropathy, or a patient with mild chronic kidney disease that has worsening of the chronic kidney disease, and then you find out, you order an SPEP and you see there's a monoclonal gammopathy. So what we need to do is to either be able to get them together and say, yes, there is an association because there's no other reason for this, anemia or renal dysfunction, or no, we have two completely different entities.
Right, because if we add renal dysfunction to that third category, I'm almost like screening everybody over the age of 60.
Yes.
Is there any clinical pearls in terms of how these things typically present that would be more suggestive of a multiple myeloma or MGUS, like in terms of the neuropathy? Is that, what does that clinically look like when it's actually being caused by, say, more?
This is a good question and a difficult one to answer, because specifically talking about plasma cell dyscrasias, all of the end organ damage that we see are so non-specific, right? And can be found with a myriad of other disorders. So what I think is, if you have a patient that already has an abnormal baseline and you see a progressive, especially fast-paced worsening in that baseline, and the patient has a monoclonal gammopathy, then definitely that patient warrants further investigation and very likely a referral to us, because we see those awkward cases all the time. So we'll be able to manage the patient in that way, in terms of expediting screening and so on and so forth. Yeah, so that we don't miss the mark.
Just one last part. So sometimes when I do this screening, it comes back with polyclonal gammopathy. Can you just talk briefly about that approach? Because if you look at the differential for polyclonal gammopathy, it's pretty long.
I couldn't hear you. Can you repeat?
Oh, yeah. So sometimes when I do the screening, it comes back with polyclonal gammopathy instead of monoclonal. And when you look at the differential for polyclonal, it's pretty long. Could you talk briefly about the approach for polyclonal gammopathy?
Polyclonal gammopathy is reactive, right? So we don't need to worry about it. You should never worry about a plasma cell dyscrasia with the polyclonal gammopathy because it's going to be related to an inflammatory or infectious disorder. It's not going to be intrinsically hematological because it's not clonal, monoclonal. Okay?
I'm just going to add a comment with that just because, just like Martha, I really like plasma cell dyscrasias as well. And I think the reason that the SPEP should always kind of be considered with the serum-free light chain is because some monoclonal disorders only produces light chains. And if that burden of light chain is not high enough, it's not going to show up in your serum protein electrophoresis. So there could be a situation where a light chain producing plasma cells may not be detected earlier on with a serum protein electrophoresis by itself. But this lends to a problem because then you'll be screening a lot of people and you're going to get a lot of serum-free light chain that is slightly abnormal. And then the next question is what you're going to do with that answer. And so serum-free light chain in itself, it's a surrogate for clonality. So it doesn't really confirm clonality, it confers clonality. So if you have one light chain that's overproduced than the other, it makes you suspicious that there is a monoclonal process on the go. And so for you to really understand, which is which, the immunofixation would be the best bet forward. And so if you do have someone with a serum-free light chain that's abnormal, you don't have an understanding for it, I would usually do a 24-hour urine protein electrophoresis with immunofixation because the immunofixation has a higher sensitivity. Certainly, there are multiple different conditions that can lead to serum-free light chains being deranged. The most common being chronic kidney disease. So people have chronic kidney disease, they tend to retain kappa light chain as opposed to lambda light chain. And so if you see a patient with chronic kidney disease and the lambda is highly retained, much higher than your kappa, then you really need to think that perhaps something is odd, something's not right here. Whereas if it's kappa and it's within a ratio of 3, that is more often than not a retainment or increase in the polyclonal component of your light chains. When it comes to the clinical picture, just like as Dr. Louzada mentioned, they are very varied. There are some tools that perhaps could kind of help you clue into whether this neuropathy is important or not. And EMG is really the next best test to help guide you through. How this can be helpful is if it's demyelinating, then we usually worry about things like anti-MAG antibody associated neuropathy. If it's normal or showing some axonal changes, in those situations, amyloidosis may still be in your clinical picture, partly because their EMG tends to affect small nerves and therefore may not necessarily show up on your EMG test itself. So there's another question from the chat. I'll ask this to Dr. Louzada. Free light chain costs in the community. Trina from chat said it's $58 from Life Labs. I guess the question is, yes, it's $58 in Life Labs. Thank you, Trina, for the price. We recognize this is expensive, but Martha, how would you counsel a patient that you're going to suggest that they need a serum-free light chain? And what's the threshold you would use to decide if a patient in the community needs this test?
Yeah, so usually when I'm sending the patients back to the family doctors, I always mention that a free light chain would be the ideal test for them to continue to have on an annual basis. And I talk about $50 to $55. Now I'm going to say $55 to $60. And really, I have never had a negative from anybody because they understand they're going to be doing this once a year. Because they are being followed by the family practitioners who I understand are not seeing these types of patients very often. I think it's reasonable to do the FLC on an annual basis. So I usually recommend that that's done I don't really differentiate between, unless the patients are low risk, right? If they're low risk, then I don't. But if they're intermediate or high risk, I'm always recommending that the FLC is done.
And also, I think us as a group usually do dictate a note kind of indicating what sort of test to be sent. Sometimes certain patients just are very efficient at producing the heavy chain. And in those patients, you can reliably follow their disease with a serum protein electrophoresis and may not necessarily need a light chain. So there are going to be some situations whereby you're going to use one more than the other. If a patient is only a light chain MGUS, unfortunately, the only way to follow this patient is a serum-free light chain.
Yeah.
And so maybe another question to Dr. Louzada. If a patient was seen by the hematology team at the London Health Science Centre, diagnosed with an intermediate risk MGUS, discharged back to the family physician, when should they start wondering about referring back? What are the kind of either red flags or telltales that perhaps requires early attention?
Right, that's a great question. So you should always consider referring if you see that consistently abnormalities are happening to the patient in the blood work. So let's say the kappa light chain is doubling up, or it's definitely, if it's a kappa chain that was, let's say below, not a kappa, sorry, a monoclonal gammopathy that's below the 15 range that we were talking about. If it is above 15, that's number one. If you have a free light chain ratio that was previously normal and it's now consistently above normality, but ideally above 8, the ratio, that's when we would consider reassessing this patient. Or if you suspect that a patient has any potential new CRAB features. Increase in the monoclonal peak level. If you have an increase in the monoclonal peak level of 25 to 50%, that's happening on a more consistent basis, then you should consider referring back. And a point that I state here for you is if you see that the levels are getting in the wrong way, then don't wait to see the patient in another year or 6 months, right? Perhaps bring the patient in 8 weeks or 12 weeks, repeat all the tests again to make sure that the patient is doing well. And then if those numbers are still going up, then you say, okay, I'm gonna send you to the hematologist again to make sure we're not missing anything important here. Does that make sense?
Any other questions? Yes.
Incidence of diabetics having this problem?
Can you repeat?
Is there a higher incidence of diabetics having this problem because they're already associated with chronic renal problems?
Well, yeah, we have a very strong diabetic population, right? Diabetes is very prevalent. So a lot of our patients will have chronic kidney disease. A lot of our patients will have diabetes. I do not have numbers on whether patients with those type of chronic, especially metabolic disorders, have a higher incidence of MGUS. I think it's sometimes a little bit more tricky to assess them because of the diabetic neuropathy, because of chronic kidney disease associated to diabetes or not. So it's always a bit tricky. And these are the types of patients that we usually like to see to help you discriminate where they fit in terms of monoclonal gammopathy.
And just a quick comment, right now we really don't know. I think there's going to be selection bias as these
Yeah.
patients generally have neuropathy as mentioned,
Yeah.
they have nephropathy, so you're going to test them more often, so you're going to pick them up more lightly than someone else. But what's really cool with the iStop-MM trial now is that this is a trial that's run in Iceland, and they are basically testing everyone. And so there's going to be a population-based data that we are anticipating that would tell us about the incidence of these associations, including the need to screen patients in the future.
Just a clarification as to when to refer back to hematology. You're saying if we see those abnormalities on a consistent basis, what do you mean by consistent basis? Do you mean I check every 6 months, or do you mean I've checked now, I've seen that something has spiked and I bring them back how soon to talk about symptoms and to repeat the labs? What do you mean by consistently seeing those abnormalities?
Yeah, so I alluded to that a little bit. So obviously, I'm happy to repeat. There's no standard recommendation in that regard, but I will give you the example of what I do. If I have a patient in clinic that I see that the monoclonal gammopathy is higher. So let's say I have a patient with a monoclonal gammopathy of 10, then I see the patient today, it doesn't matter. Maybe I saw the patient 6 months ago, but today the monoclonal gammopathy is 15. So this is a 30% increase. So I worry, right? I don't like to see that. So instead of seeing the patient in another 6 months, I'm going to bring that patient in probably 6 to 8 weeks at the most to reassess, and then I will look at that number. The number is now 17. So, okay, it's not that bad. It was 15, 17. I'll continue to follow you closer. So I'll see you again in about 8 weeks. Make sure that you get a plateau, because those plasma cells, they go up and down, right, in their production of monoclonal gammopathy. And sometimes they are a little bit more active, but then they plateau, and they can plateau for a long period of time, sometimes years. So you just know that you went from a baseline of 10, now your patient's baseline is 15, but it's still okay because they go 15, 16, but then you see, okay, this 15 came up to 22. You don't like that. So that's when you say, okay, I'm probably out of my comfort zone here. Let me ask a colleague from hematology to reassess. I think that's reasonable. And the issue with the serum free light chain is very important, because sometimes you see a free light chain that's the ratio is like 1.87, right? So it's slightly above normality. That's probably meaningless. I can never say it is meaningless, but it's very likely to be meaningless. So you need to repeat again and make sure, that's not because of an acute renal dysfunction. That would be the most sensitive cause, as Dr. Pua was alluding to. Actually, the iStop-MM trial is also looking into this and proposing other assessments regarding ratio for the free lights. But in general, free light chain ratio that's up to 3 is most likely associated to renal dysfunction. Many times you have an abnormal ratio, but your kappa and lambda are within normal absolute numbers. So those are also not of clinical significance. Okay, so little things to try to remember when you look at those results.
Okay, thank you, Dr. Louzada.